Hello everyone, my name is John Massey. I'm a graduate student at the University of Southern Maine School of Nursing. This is my presentation for Advanced Pharmacotherapy Summer 2020. My patient's name is Bradley Cooper. Patient presents as a 45-year-old Caucasian male with the date of birth of 1/5/1975. His chief complaint is that he's had a persistent rash on his groin for over a month that has not subsided after treatment with nystatin cream and over-the-counter Lotrozone. He says that it is severely affecting his ability to shoot his movie, and it is quite bothersome and annoying. Patient privacy is a little bit of a concern because he presents with members of his entourage today after a long day of filming on the set of his latest movie. Patient's height is 6 foot 1 inch, weight is 183 pounds or 83 kilograms. Vitals upon presentation to the office are blood pressure of 120/80, pulse of 64 beats per minute, respiration rate of 16, and his temperature is an average 98.6 degrees Fahrenheit. So Mr. Cooper's history, his medical history, his most recent physical performed by his primary care provider states that Mr. Cooper is in overall excellent health. He has prior substance use disorder history of alcohol and opioids, but has maintained sobriety for the past 12 years. He had a prior depressive episode during his period of substance use, but remains in remission to this day. He has no known allergies, no known drug allergies, and he receives a seasonal influenza vaccine annually. No history of dermatological problems, so this is a new issue that he's encountering today. He had cholesteatoma as a child, which is a growth in your inner ear, and he also punctured an eardrum when he was diving as a child, but other than that, no significant medical history. Current medications include nystatin cream. He's been applying 100,000 units per gram 2 to 3 times per day to the affected area as prescribed by his PCP for the past 2 weeks with no resolution of rash. Prior to the nystatin, he was applying Lotrozone 1% over-the-counter cream 2 to 3 times a day to affected area with no resolution. For surgical history, he had an Achilles tendon repair surgery. The date on that was not known. It was anecdotal, provided by the patient, and no complications with that surgery, though. Social history, he's currently single, previous relationship with Irina Shayk, and has a 3-year-old daughter from that relationship. History of present illness. Mr. Cooper states that he noticed some skin discomfort in his groin area about a month ago after filming a desert scene all day in California. Mr. Cooper states that he has never had a problem like this before. This is consistent with his report of having no dermatological issues. Initially, Mr. Cooper thought that his discomfort was due to chafing that occurred the day before as he was filming all day in jeans. He applied aloe vera at the advice of his makeup artist to soothe the itching with some noted relief. However, the rash spread, prompting Mr. Cooper to be seen by the on-set nurse, who thought that perhaps he had Tinea puris Jokic, and gave him some Lotrozone to apply to his groin. After a week with minimal symptom relief and the area becoming further inflamed and itchy, Mr. Cooper decided to schedule an appointment with his PCP, Dr. Albion. She advised Mr. Cooper that his symptoms seemed to be typical of an infection caused by Candida albicans. Dr. Albion prescribed a course of topical nystatin cream and instructed Mr. Cooper to seek treatment if symptoms did not resolve within 2 weeks. Mr. Cooper presents today and is a bit agitated as he is sick of having to put ointment on as it interrupts his daily schedule. He states that he has neglected to put ointment on every day and has skipped applying it several days intermittently. Upon exam, the patient presents with a red growing erythematous rash consisting of reddish macules appearing on skin around genitals, and part of buttocks. Fine scaling and distinct border are present, along with several satellite lesions along the border. Mild folliculitis and maceration present bilaterally on inner thighs, and slight excoriation appearing due to scratching. No lichenification present. No cutaneous or hand-foot involvement or rash appearance elsewhere on the body. So given the patient's history and his history of treatment, my initial impression is uncontrolled treatment-resistant candidiasis infection. Given the possibility of several different fungal strains, it could be C. glabrata, C. parapsilosis, C. tropicalis, or C. auris. And if it's C. auris, we would have to take necessary contact precautions. Several differentials that could be the case. It could be a bacterial infection, which oftentimes may occur in adults. There are different kinds, and it's very difficult to single out. One potential possibility is that it is erythrasma, which can be diagnosed with in the office with a specific type of light that might be shown on to the site, although the presentation in the case of this patient doesn't seem to point to erythrasma. And since this patient has already presented several times to several different providers and has not had any sort of eradication of the symptoms, it might warrant being referred to an expert, such as a dermatologist. The patient could also be experiencing psoriasis, which is somewhat unlikely given that he has not experienced anything like this in his life before, although it's still not something that should be ruled out. And it could also be tinea. It could be jock itch or ringworm, but given that he has already applied lotrozone, it doesn't seem like that would be the case because it would most likely be ruled out. Although, given the patient's dislike for ointments and creams, it seems like he might maybe have applied the lotrozone inconsistently, as he did with the nystatin. So our treatment options, given that Mr. Cooper has already tried 2 different medications, there's an indication that this might be treatment-resistant candidiasis, it is important to conduct potassium hydroxide preparation, skin culture, and potentially a biopsy if indicated. If this were to happen to be C. auris, I mean, even in the event that it isn't, we still would want to take contact precautions, wear gloves, and be very careful when we're working with this patient. We'd want to follow protocols established by the CDC if there were a positive indication of C. auris. When discussing this with the patient, the possibility of another cream or an ointment is definitely out of the question. He's emphasized that he does not want another ointment or cream, and given his hectic schedule and filming schedule, he's not able to comply with that regimen. So this limits the options that we have, as many of the medications that are next in the standard line of treatment, such as butetafine, iconazole, and itraconazole, are topical. So a potential option that I would consider administering is fluconazole, which is diflucan. It's a broad-spectrum imidazole that can be administered orally, and its use is supported by evidence-based research. It's theorized to work by inhibiting the enzyme that's responsible for fungal cell membrane growth, so it actually affects cytochrome P450 and inhibits the enzyme that leads to construction of the fungal cell membrane. But it's considered more advantageous when compared to other azoles, as it doesn't affect cytochrome P450 strongly, so it won't interfere with metabolism of other medications, even though the patient he's reporting that he's not on any other current medications, not even NSAIDs or anything over the counter, other than the nystatin and the lotrozone. And something else that we'd want to consider is a referral to a dermatologist, particularly if this patient reports no ceasing of symptoms after 7 days. So when administering fluconazole, we're going to want to tell the patient to take 200 milligrams a day for 7 days. Some of the side effects that might occur with this medication are nausea, stomach pain, diarrhea, upset stomach, headache, dizziness, changes in sense of taste. Those are some of the more common side effects. There are some more rare side effects that, such as QT prolongation, that we want to watch out for. And some of the interactions that might occur we shouldn't be administering this medication if the patient was on terfenadine, erythromycin, cisapride, or any SSRIs. The patient, even though he had a prior depressive episode, he states that he was never on any medication for that depressive episode, and he's not currently on any other medications, so we should be okay in that regard. He says he doesn't remember if he's ever taken diflucan before, but he says that he has no known drug allergies. But I told him I assured him that if he had any sort of interactions, to call the office. So some additional education. We want to make sure to inform the patient of the importance of drying the affected area thoroughly after bathing, just ensuring that the area stays dry. We don't want any excess moisture in the area, as this could further speed up fungal growth. We want to make sure that he wears absorbent materials such as cotton underwear and avoid constrictive clothing, particularly when he's being active and working on set. We want to consider counseling the patient on applying talc or antifungal powder to the affected areas, and we want to advise them to stay away from any products containing cornstarch, since cornstarch is based in, it has carbohydrates in it, which would further allow the fungus to thrive. So we would want to advise the patient to follow up within several days, just to let us know if he's feeling any better. It might take up to 2 weeks for the full medication, for the full effects to be apparent of the medication. If the rash happens to worsen or spread to other parts of the body, or if no improvement is seen in 7 days, we would want to advise Mr. Cooper to call the office. And if the rash is unresolved or gets worse, we'd want to refer him to a dermatologist. Evidence-based practice shows that most candida infections they clear up on their own volition, and very rarely is it treatment resistant. But just erring on the side of caution here, we want to make sure that all of our bases are covered and ensure that Mr. Cooper has everything taken care of and he starts to get better. So in the event that his rash does not clear up, we'd want to make sure that we get that referral done. So Mr. Cooper called your office a week later and informed you that the oral fluconazole worked like a charm and cleared up his supposed candidiasis. He's so relieved and grateful that he invites you to fly with him on his private charter jet to Ibiza for the weekend. Thank you so much for listening, and feel free to reach out with any questions.